I'm going to go over the 2025 guidelines and kind of do a stepped process of how we're going to tackle this today. The course itself is about an hour to an hour and a half, seeing how it goes. After this, you have to have completed the skills component as well as the written exam. From there, you will have a course completion e-card issued to you afterwards. So I'm going to get started with some videos here and some overview aspects afterwards.
Heart disease is the #1 cause of death in both men and women globally. It claims more lives than all forms of cancer combined. Cardiac arrest is always a medical emergency, and it can affect all ages, genders, nationalities, and races. In cardiac arrest, blood stops flowing to the brain and other vital organs. Cardiac arrest is most often caused by a cardiac issue in adults and respiratory issues in children and infants. Cardiac arrest is often fatal if the appropriate interventions are not taken immediately. This is why early recognition and immediate cardiopulmonary resuscitation, or CPR, are crucial for survival. Basic life support, or BLS, including CPR, is the foundation for saving lives after a cardiac arrest. Advanced rescue measures cannot be successful on their own without high-quality BLS skills. Healthcare professionals are the backbone of the systems of care in both the in-hospital and out-of-hospital settings. In this course, you'll learn the essential skills of BLS, including high-quality CPR for people of all ages, and you'll practice BLS skills, both as a single rescuer and as part of a multi-rescuer team.
There we go. Sorry for the delay. So the 2025 BLS summary table here, the big changes are the change of survival. So where we used to have in 2020 a sixth length recovery was added to the adult and pediatric in-hospital and out-of-hospital chains of survival. In 2025, that chain is now a single chain instead. So it is intended to apply to not only the adult algorithm, but as well as the pediatric algorithm within in-hospital cardiac arrest and out-of-hospital cardiac arrest. So they acknowledge that before a cardiac arrest, prevention and preparedness can avoid and optimize the resuscitative efforts. So making sure that we can get the cavalry going and making sure that the therapeutic care is taken care of before cardiac arrest happens. The other addition was that with infant chest compression, the change from 2020 to 2025 is that we are not recommending the two finger on the chest as we did previous. Now it's either two thumb encircling technique or the one heel of the hand on the chest is the recommendation. What we're noticing is that the two finger technique did not perform and people were getting tired. They didn't get the depth that is needed, which is 1/3 of the anterior posterior aspect of the infant's chest, or approximately 1.5 inches. So we're seeing that as well. We're also adding a definite aspect of opiate-associated emergencies. So where there was some talk about opiate-associated emergencies in 2020, in 2025, the adult BLS algorithm illustrates the role of opiate antagonists like naloxone for those suspected overdoses where respiratory and cardiac arrest might happen. There is no longer a separate associated algorithm for that. There was a change for severe foreign body airway obstruction for infants. What the change was that now, instead of doing the two finger method on the chest thrust, we are now doing the one heel of one hand on that. So that change is also going to be important because we're not seeing that depth that we need to overcome that foreign body airway obstruction. So you're going to start with the back slaps or back blows, and then you're going to rotate the infant, supporting the head and neck, and then you're going to do chest thrusts with the heel of one hand um, until either they expel the plug or they become unresponsive, which then you would start CPR. These next two are very important. In 2020 and even years before, I believe 10, 15 years ago, with the adults and children, the AHA recommended only abdominal thrusts until the object is expelled or they become unresponsive. As of 2025, the change is that now we're doing 5 back blows or back slaps between the shoulder blades, and then we're doing 5 abdominal thrusts. And we're going to alternate that until the object is expelled or they become unresponsive. And that's for both children and adults. So there's also some changes to the algorithms between the pediatric and the adult, where now the term that we're using for the pediatric BLS algorithm, infants to puberty, is to start talking about after signs of puberty are there, we're going to pivot and go to the adult side of things. If not, then we're going to stay in the pediatric BLS. So that is just a wording change, but they're also changing and updating the role of opiate antagonists within an opiate overdose. So that's just something to keep in mind as we're talking about these algorithms and the changes. Let me change my screen here. I just want to give a quick glimpse of how these algorithms look like once we dive into some more videos here. But essentially, this is how these are now changing. So you have an asterisk here for the change of term, which is defined if signs of puberty, treat as adult. That's the big one here. But other than that, that's what it looks like. So from the get-go, we want to verify scene safety. We want to make sure that we go home safe to our family and friends. We're not exposed to any environmental issues, poisons, toxins, traffic, simple as traffic, or other environmental safety issues. So just be aware of your scene, make sure you're safe if you can, rescuing the individual. If not, definitely call for help. Check for responsiveness. We want to make sure that we are tapping and shouting. We're going to not only tap for responsiveness, but we're going to shout loud enough that other individuals nearby may respond to help. From there, activate the emergency response system. Be aware. What does that mean for you? If you're lay rescuer in your neighborhood, at the store, 911 will probably be the de facto standard of getting emergency response activated. A lot of healthcare professionals work in an environment where they might have a rapid response team, code blue team, or something to that effect. Make sure you're aware of those phone numbers and or access panels, buttons, whatever the case may be, to activate those emergency systems. Sometimes 911 in those systems will go to a centralized call center within the facility, and sometimes you have to dial 9911 or 7911, whatever the case may be, to get to external 911. So just be aware of your your emergency response system. Make sure that when somebody does respond, they are delegated to go get an AED. The idea is you just don't say, hey, I need an AED. Hey, somebody call 911. Hey, probably nobody's going to do that. Maybe somebody will. But it helps if you delegate a person, an individual, to say, you get an AED, you call 911. From there, they have a job to do, and they do it. That's kind of the thought process. So I also want to let you know that once we're there, we're looking for breathing or not. If they're gasping or have signs of agonal breathing, that's usually a sign of cardiac arrest. So we want to make sure at the same time we're looking at the chest, we're feeling for a pulse on your side. So usually you want to go carotid. You can go for femoral in the adults, but make sure, is there a pulse? And if you're not sure, within 10 seconds, start CPR. So if they're breathing, or they look like they're breathing, but they're unresponsive, then you want to monitor until advanced care arrives. If they're abnormal breathing, provide rescue breaths, 1 breath every 6 seconds or 10 breaths a minute. Make sure you're checking those pulses. Just because they have a pulse now doesn't mean that they have a pulse in 2 minutes or less. If you suspect an opiate overdose, do not hesitate to give them naloxone or any opioid antagonist. So if they're not breathing, there's no pulse, start CPR. We're performing CPR compressions of 30 compressions to 2 breaths. We want to make sure that we're compressing to at least a depth of 2 inches. Those breaths are given over 1 second apiece. You want to be forceful enough to have chest rise and fall, but not so forceful that you're going to inflate the stomach. We want to minimize gastric inflation, which increases intrathoracic pressure, decreases the cardiac output, as well as the potential of aspiration and vomiting. So just something to think about. If you suspect an opiate overdose, once again, give naloxone as long as it does not interfere with compressions. The second that an AED arrives, you want to turn on the AED and listen to the prompts. So those are the 2 steps. Turn it on, listen to the prompts. We'll talk about more of this later. From there, the AED is going to make a decision. If the decision is going to shock, right? It's going to shock. It's going to charge and deliver the shock. If it's not shockable rhythm, start CPR. Either way, do not delay compressions. If it delivers a shock or you deliver a shock, start CPR. If it doesn't deliver a shock, start CPR soon thereafter. So that just kind of dives into the adult algorithm. A lot of this comes from sciences where they're noticing that there is a delay of care. The data has come in, they're taking a strong reaction to minimizing interruptions. So I believe in 2020, they started talking about a compression coach, a CPR coach. That's not going away. That's still there. So we'll talk more about that as far as the course goes on. But without further ado, let's talk about the chain of survival.
Approximately 960 people have a cardiac arrest each day in the United States. With the training you receive in this course, your actions can give a person the best chance of survival. High-quality CPR and defibrillation can double or even triple the chance of survival for someone in cardiac arrest. For every minute that passes before someone takes these life-saving actions, the person's chance of survival decreases by about 10%. Cardiac arrest can occur without warning or within just a few minutes after symptoms appear. The term heart attack is sometimes mistakenly used to describe cardiac arrest. Although a heart attack may lead to a cardiac arrest and sudden death, they are different conditions. A heart attack occurs when a blood clot blocks oxygen-rich blood from reaching the heart. When this happens, the heart muscle starts to die of hypoxia, or a lack of oxygen. As a result, cardiac output decreases because the heart can't pump enough blood throughout the body. In cardiac arrest, the heart stops beating and no longer pumps blood or oxygen to the body's vital organs. A heart attack can lead to cardiac arrest. Cardiac arrest can also happen because of an arrhythmia or an electrical issue within the heart. Other causes can be severe blood loss, breathing issues, drowning, drug overdose, severe allergic reactions, or a traumatic injury such as commotio cordis. Commotio cordis is a rare cause of cardiac arrest that can happen after someone is struck in the chest by an object, like a ball, a puck, or another person during a specific point in the heart's rhythm cycle. It's more common in young people, likely because of their thinner, less developed chest walls. In a small number of cases, commotio cordis is caused by other types of physical trauma, such as a car accident or an assault. No matter the cause, the signs of cardiac arrest are the same. Cardiac arrest may start with someone collapsing, followed by a lack of responsiveness and no breathing, pulse, or heartbeat. Your provider manual includes more information on the differences between a heart attack and cardiac arrest. Despite these differences, it's critical that rescuers follow the chain of survival for both conditions to give the person the best chance of survival. Each link in the chain of survival represents the important interventions applicable to adults, children, and infants, both in and out of the hospital. The links include recognition and emergency activation, high-quality CPR, defibrillation, advanced resuscitation, post-cardiac arrest care, and recovery and survivorship. There is a separate chain of care for newborns because they require different interventions. The links include prevention, recognition and activation, initial steps, ventilation, advanced resuscitation, postnatal care, and recovery. In the in-hospital setting, interventions focus on prevention and early recognition of cardiac arrest, with patient monitoring and assessment, and if necessary, rapid response by the medical emergency team when a patient's condition starts to deteriorate. Watch as we take you through the chain of survival in an in-hospital scenario. A daughter has brought her father to the hospital for routine lab work. As the father and daughter are walking through the hospital entrance, the father collapses.
Are we late?
No, we're fine. Dad! Dad, can you hear me? Help! Somebody help me!
First, the nurse assesses the scene quickly to make sure it's safe.
Hey! Are you okay? Are you okay? Activate the emergency response system and get an AED.
He doesn't respond. He's not breathing normally, and he doesn't have a pulse. The nurse immediately recognizes the signs of a cardiac arrest. It's important to note that abnormal breaths, called agonal gasps, are common in the first few minutes of a cardiac arrest. Agonal breathing may sound like a gasp, snort, snore, or groan. Rescuers can sometimes mistake agonal breathing for normal breathing and fail to recognize cardiac arrest and initiate CPR. Seizure-like activity can also occur with cardiac arrest. If the person is not responsive and not breathing normally, you should start CPR. We recommend that all locations and organizations have a cardiac emergency response plan in place, which outlines specifically who responds and what to do in a cardiac emergency. In the scenario you just watched, you saw the chain of survival in action as the nurse assessed the situation and recognized a possible cardiac arrest. She activated the emergency response system and told someone to get the AED, or automated external defibrillator. The nurse then immediately starts CPR. Be aware that both lay rescuers and trained rescuers who are not comfortable providing breaths may provide compression-only CPR, also called hands-only CPR.
16, 17, 18, 19, 20, 21, 22, 23.
Trained rescuers like you might find it necessary to provide compression-only CPR until a barrier device, pocket mask, or bag mask device is available. But giving breaths is especially important for infants and children because respiratory distress is a common cause of cardiac arrest for these age groups.
16, 17, 18, 19, 20, 21, 22, 23, 24, 25.
You may interact with lay rescuers who have started hands-only CPR when they see a teen or adult collapse suddenly. Lay rescuers are encouraged to follow 2 simple steps for hands-only CPR. Call 911 and push hard and fast in the center of the chest. The 911 telecommunicator may provide further instructions, including step-by-step coaching on how to perform CPR until emergency responders arrive. Defibrillation with an AED is the next link in the chain of survival. You can use an AED on anyone in cardiac arrest, even an infant, a child, or a pregnant person. Most cardiac arrests are triggered by abnormal heart rhythms called arrhythmias. The most common and treatable arrhythmias that cause cardiac arrest include ventricular fibrillation and pulseless ventricular tachycardia. With ventricular fibrillation, the heart's electrical impulses suddenly become chaotic and ineffective. Blood flow to the brain and other vital organs stops abruptly, and the person loses consciousness. In pulseless ventricular tachycardia, the heart contracts too fast, preventing the ventricles from filling with blood, and eventually blood flow to the body stops. Without blood flow, a person has no pulse. Both ventricular fibrillation and pulseless ventricular tachycardia require CPR until an AED is available. In both rhythms, death usually follows unless a normal heart rhythm and pulse are restored within minutes. An AED is used to treat cardiac arrest. The AED works by analyzing a person's heart rhythm and delivering an electrical shock to the heart if needed. The shock resets the heart's rhythm, causing it to start pumping blood to the brain and to the rest of the body again. This may sound scary, but an AED will not deliver a shock unless one is needed. The AED is easy to use. All you have to do is turn it on and follow the prompts. We will learn more about how to use an AED later in the course. Rescuers trained in advanced resuscitation provide more advanced treatment, such as giving medications or performing advanced airway interventions. Advanced resuscitation builds on the foundation of basic life support, extending the chain of survival and giving the person the best chance of survival. Once the return of spontaneous circulation is achieved, the person receives post-cardiac arrest care. Post-cardiac arrest care after return of spontaneous circulation focuses on preventing the recurrence of cardiac arrest and improving long-term survival. Recovery and survivorship from cardiac arrest continues long after hospital discharge and includes physical, emotional, and ongoing support. These links in the chain of survival outline the most important interventions to treat cardiac arrest. Your ability to provide high-quality BLS can help save a life. Now we'll focus on the individual skills that rescuers perform during BLS. It's most effective to perform CPR as a team, but to be an effective team member, you'll need to learn the skills of CPR first.
So a lot of this comes into play when we're talking about the compression, early recognition, prevention, putting it all together. Here, I'm going to bring up my window here, put myself in the corner. So here we're looking at the steps of it here. So you're sitting there thinking to yourself, what do I do? You want to make sure scene is safe. You're going to tap and shout. You're going to delegate, get an AED, call 911. You're going to feel for a pulse as well as you're going to check for breathing. So that being said, are they unresponsive? Yes. Make sure that activates that emergency response system. From there, start CPR. We're going to continue CPR, pushing hard and pushing fast in the middle of the chest. Minimizing those interruptions. Interruptions should be less than 10 seconds. Now, when an AED arrives, we want to make sure apply those AED pads around the compressor. Step number 1, turn it on. Step number 2, follow the prompts. So As one rescuer is compressing, the other rescuer is working around them. From there, we're going to continue that cycle. Okay. Just a quick demonstration of what that's going to look like.
Check for scene safety.
Hey, are you okay? Are you okay? Help! Somebody help me! Activate the emergency response system and get the AED. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
So from there, as you can see, it was a very quick response of all of the components that need to happen in rapid succession. So that just illustrates that. Now I do want to talk about, before we dive into the bag valve mask, in that last video, the single rescuer had a mouth barrier, so mouth to mask barrier. That is the recommendation, is that you perform a mouth to mask if you have one, if you're comfortable mouth to mouth. But if you're not comfortable, then hands only CPR if you don't have a barrier device. That is the single rescuer recommendation. If you have two rescuers, then a bag valve mask would be ideal. Bag valve mask is a single rescuer. It kind of delays care, and then you have to then focus on the airway, getting that airway open, keeping it open, and then you do your 2 breaths. Then now you got to scoot over to the side of the individual to work on their chest. So just something to think about when you're manipulating the bag valve mask by yourself. Give yourself a thought, this is kind of hard. I should probably refrain from that and just go with a mouth to mask barrier device.
Next, we'll learn about how to use a bag mask device to provide ventilation when one is available. Bag mask devices consist of a ventilation bag and a face mask, and they come in a variety of sizes. You can use supplemental oxygen with a bag mask device. First, select a mask that's the appropriate size. The mask must cover the person's mouth and nose completely, without covering the eyes or extending below the bottom edge of the chin. If you are trained to use one, consider using an airway adjunct, such as an oropharyngeal airway, or OPA, or nasopharyngeal airway, or NPA, if one is available. OPAs and NPAs can be used by a trained professional to maintain a patent airway and facilitate appropriate ventilation by preventing the tongue from occluding the airway. Next, you'll position yourself directly above the person's head. You'll use the EC clamp technique to hold the mask in place. To do this, apply the mask by first placing the cushion at the narrow end of the mask onto the bridge of the person's nose. Then, lower the mask fully onto the face, watching for the cushion to bulge as it initially seals against the face. Next, form a C with the thumb and index finger of one hand and press down on the dome of the mask toward the face to further seal the rim of the mask. The remaining 3 fingers of that same hand should form an E to reach past the edge of the mask, along the bony rim of the jaw. To tilt the head back, lift the jaw toward the mask and open the airway. Make sure you squeeze the mask with your thumb and index finger while lifting the jaw to achieve an airtight seal between the mask and the face. Then, squeeze the bag with your other hand. If the chest doesn't rise with each ventilation, you're not providing adequate ventilation. If you don't get chest rise, readjust the mask, reposition the head and neck, and try to ventilate again. and then, only if necessary, administer a larger amount of air, just enough to get chest rise. Be sure not to provide excessive ventilation. This could cause gastric inflation, which is air going into the person's stomach instead of the lungs. Gastric inflation can cause vomiting and possible aspiration. Similar to providing breaths with a barrier device or a pocket mask, you'll do cycles of 30 compressions followed by 2 ventilations with a bag mask device. Give each ventilation for 1 second with just enough volume to make the chest rise. If you have multiple rescuers, the most effective way to ventilate with a bag mask device is to use the 2-person bag mask device technique. This means that 2 people will be at the person's head to ventilate. 1 person will focus on keeping the airway open and securing the mask, while the second person squeezes the bag to deliver ventilations. The first person will use both hands to seal the mask to the person's face and lift the jaw. The thumbs and index fingers of both hands each form a C to seal the mask against the face. And the 3 remaining fingers of each hand will form an E for lifting both sides of the jaw into the mask. Be careful not to press too hard on the mask, which could push the jaw down and block the airway. The second person will squeeze the bag to deliver ventilations. Research suggests that some rescuers are less confident and less effective when using a bag mask device on their own. Because using a bag mask device is such an important skill, we'll practice using one next.
So the bag valve mask is a 2-rescuer device, and it can be a 3-rescuer device, if you will, that 1 individual is holding the mask, 1 individual is squeezing the bag, and a 3rd individual is doing the compression. So that's just something to consider when you're in the team dynamic, who does what. The EC method is quite easy, but the difficult part is getting your hands not only around into their jaw with your 3 fingers here, but then around the mask itself with your C here. So sometimes you might have to choke up a little bit more on there. You're bringing the individual into the mask as well as pressing the mask down. You don't want to press the mask just down. You're going to occlude the airway, you're going to shift the jaw, therefore shifting the tongue and occluding that airway. So you need to adjust them, put them into that head tilt chin lift maneuver, that sniffing position, as well as getting a good seal around. Sometimes facial hair, sometimes just the size of their face. Your cheeks are going to start puffing out, but the seal is the deal. The double EC method, same idea, but now you are just 2 E's, 2 C's, and you are now bringing them in and making sure that seal is the deal. Remember, don't provide excessive ventilations. It's 1 squeeze over 1 second twice. So 30 to 2, no matter who. Something to think about, our tidal volumes, our lung capacity, 350 milliliters to about 500 milliliters, depending on the individual. So that's something to consider, especially when the bag valve mask is 1200 to 1600 milliliters. So don't give a full squeeze of the bag just to get a breath in. You're looking for that chest rise and fall. We don't want to inflate the stomach. Inflating the stomach, you're increasing the gastric pressure, which then increases the intrathoracic pressure, decreasing cardiac output, and you always have the aspect of aspiration and vomiting. So the scene just gets that much messier, and we don't want to go down that. Those individuals that are on the bag valve mask on the airway, you're going to stand at the crown of the head, and you're going to get that airway open, and you're going to keep it open. So it's not that you relax during not a breathing time. It's you get that head tilt chin lift, you get that EEC method. The other individual, the compressor is on the chest. 29, 30, they can either reach up, squeeze, or you have that 3rd individual that's squeezing the bag. Your main job is to get that airway open, keep it open. So just something to think about when it comes to the bag valve mask. We're going to start diving into the AED, the special considerations especially. So let me hit Play right there.
By this point in the resuscitation effort, additional rescuers may be available to assist you. Additional rescuers can help with ventilation and the AED while you continue performing compressions. If you're tired from performing compressions, you should switch out compressors. Additional rescuers can also help by removing the headboard of the bed so it's not an obstacle during ventilation, bringing a step stool for the rescuer performing compressions, or by placing a CPR backboard. CPR backboards can be used when a patient is on a sofa, bed, or similar soft surface, but don't delay compressions if you don't have one. Quickly position the CPR backboard so that it's centered under the person's back while you make sure to minimize interruptions in chest compressions. It's important to be familiar with the AED in your clinical area. Although AEDs may differ slightly, the actions you will perform are very similar, no matter what AED you're using. To begin, turn on the AED using the on or power button. Some devices will power on automatically when you open. The AED will instruct you what to do once it's turned on. Listen carefully to your device and follow your device's prompts for the next steps.
1, 2,
Apply
3,
pads
4,
to patient's
5,
bare
6,
chest.
7,
AED
8,
pads
9,
must be
10,
placed on bare
11,
skin to
12,
work,
13,
so remove any clothes that interfere with placement of the pads. Place one pad vertically on the person's right upper chest. The top of the pad should be just under the clavicle. Place the second pad horizontally on the person's left lateral ribs. The middle of the pad should be below the axilla at the mid-axillary line. Ensure the pads are not touching each other. Follow the diagrams on the pads you're using to help you place the pads correctly. The AED may include sets of different sized pads. The larger pads are for anyone 8 years or older, and the smaller pads are for children younger than 8 years. If you're not sure of the person's age or you don't have pediatric pads, use the adult pads. You may need to place the pads in an antero-posterior placement, especially on a child's or infant's chest so they don't touch or overlap. If you're using an AED on a child or an infant, use the child setting. Or if a pediatric attenuator is available, use it. A pediatric attenuator, when attached to the AED, decreases the shock dose. If an infant needs defibrillation, a manual defibrillator is preferred. This device is quite different from an AED, and it requires special training that's not included in this course. If a manual defibrillator isn't available, an AED with a pediatric dose attenuator is preferred. But if neither are available, you may use an AED with pediatric pads without a pediatric dose attenuator. You may need to plug in the pads connector if the pads aren't already good.
Plug-in pads connector.
Some AEDs will tell you to press a button on the device to analyze the heart rhythm. Others will analyze the rhythm automatically.
Analyzing heart rhythm. Do not touch the patient.
The rescuer operating the AED is responsible for shouting, "Clear," during rhythm analysis and again before pressing the shock button, if advised. While the AED is analyzing the heart rhythm, the compressor could switch roles with another rescuer if needed.
Clear. Let's switch.
Okay.
If a shock is advised, the AED will charge before you can press the shock button.
Shock advised. Charging. Stay clear of patient.
Check visually to be sure that all rescuers, including lay rescuers, hear the prompt and follow it, even the person giving breaths. Shout, "Clear," and make sure that no one is touching the person before you press the shock button.
Deliver shock now. Press the shock button now.
Clear.
Shock delivered. Start CPR.
After the shock is given, resume chest compressions immediately. Delivering a shock may produce a sudden contraction in the person's chest muscles. Don't remove the AED or turn it off. The device will repeat the analyze and shock cycle about every 2 minutes, which is approximately 5 cycles of 30 chest compressions and 2 breaths. If at any time the AED indicates that no shock is advised, immediately resume cycles of 30 chest compressions and 2 breaths until prompted by the AED or additional emergency responders arrive. You'll need to consider a few special situations when using an AED. Before pad placement, remove all clothing and jewelry from the chest and apply the AED pads to the bare skin. If chest hair is preventing from sticking, you may quickly shave the area if a razor is available. If a razor is not available and you have 2 sets of adult pads, apply 1 set of pads to the hairy chest. If the chest hair prevents the pads from contacting the skin, the AED will tell you to check the pads. If it does, press the pads down more firmly. If they still aren't sticking, rip the pads off forcefully, removing the chest hair. Then, apply a new set of pads to the bare skin. Excessive sweat or water on the person's chest can also be a problem. It could allow the shock to travel through the water between the pads, ultimately preventing delivery of an effective shock dose to the person's heart. If the chest is covered with water or sweat, wipe the liquid off before attaching the AED pads. Wipe the chest quickly. It doesn't have to be completely dry. If the person is in water, quickly move them to a dry area before using an AED. But if the person is lying on snow or in a small puddle, you can still use the AED. Some people have an implanted pacemaker or defibrillator in the same place where you would put the AED pads. These devices look like a round or square lump that's smaller than a deck of cards. If you see this lump, avoid putting an AED pad directly over it. Instead, place the AED pad to the side of it. Do not place AED pads on top of a dressing, a medical device, or a medication patch. If you notice one of these items, place the AED pad next to it, making sure the pad is not touching it. Lastly, AED kits may include additional emergency equipment such as scissors, razors, wipes, gloves, and a barrier device such as a pocket mask. These items may also be found in a separate emergency or first aid kit. Familiarize yourself with the AED in your workplace and follow the manufacturer's instructions. Regardless of the type of AED, remember to turn it on first and follow the audible prompts that will lead you through the rest of the steps. We'll pause here to allow you to get familiar with the AED in your class. Your instructor will show you all that's included in the kit and demonstrate the correct way to place the pads on a patient.
So the AED, it's a great tool. Think about this. The AED itself is there to stop an abnormal rhythm in hopes that a normal rhythm starts up. So your heart, it's quivering, right? Just an example of ventricular fibrillation. The AED comes along and stop. That's what the AED does. Just something to consider. It's a great tool. It's found pretty much anywhere. Planes, trains, automobiles. It's at the airport. I believe 2 minutes in any direction. Usually there's a telephone next to it, so be aware where the AED's in your location. So a little bit of homework, everybody. Go find your AEDs. Find out how long it takes you to get there from your everyday location. Also, be mindful. Some of the AEDs have doors and buttons and bells and whistle sirens that the boxes may work, may not work. So consider that. I recommend if you pull an AED, dial 911 and activate the emergency response system. We're not sure what's out there. There's some boxes that do that automatically, some boxes that don't. Just so something to consider. Turn it on, follow the prompts. Turn it on, follow the prompts. Turn it on, follow the prompts. Those are the 2 steps that you need to know. Just be aware that now more and more organizations, you're seeing AEDs that are not automated external defibrillators. They're automated external defibrillator. So MACE basically is you set it and forget it, if you will. You turn it on, follow the prompts, right? So sometimes it's apply pads to patient bare chest, plug in pads connector, and then from there it'll analyze. Make sure we're clearing these individuals, look, listen, do something about it. AEDs do not know if this individual has a pulse. You are the one that know if this individual has a pulse. So that's just something to consider as well. If you're touching the person that's in cardiac arrest, it might pick up your heartbeat, your electrical activity, and advise that this individual might not need the shock, even though they actually do. So that's one thing. And then when it's time for the shock, if it's an automatic AED, then it will start a countdown, 3, 2, 1, shock delivered. So make sure, look, listen, do something about it. Clear, I'm clear, you're clear, we're all clear. Don't get an itchy trigger finger if you have a AED that you need to press the button, or if somebody needs to press the button. So just something to keep in mind. The other thing is that we're starting to have other methods of applying AEDs where they used to be anterior lateral placements. Now we're looking at anterior posterior placements right at the base of the scapula. So just something to consider. I've seen pad placement side to side, axilla to axilla, and then your anterior posterior, making sure that they don't overlap. So sometimes you have to do that because of implanted devices like AICDs, pacemakers, and things like that. Just be aware of that. Other special considerations is if the chest is wet or it's a small puddle, wipe the chest. The idea is so we can get electricity through the body, not over the skin. If they're in a large body of water, they have to be removed. Please don't use an AED in a large puddle of water. Snow is fine to use on, as long as it's kind of, I don't want to say the white fluffy stuff, but it's not a puddle of water hiding underneath it. So you want to work around the compressor. Please try not to interrupt the compressor. Once again, BLS, the compressions, they are key. If there's any patches, medication patches, lidocaine patches, fentanyl patches, any other nicotine patches, work around them. If you have to remove it, you please put some gloves on. We don't want to expose each other to any of the patches or the medications that are within those patches. So that's just something to consider. If this individual has a hairy chest, shave that area if your AED kit has it. If not, if it has 2 sets of pads, put 1 set of pads on, and if it's not working, you can rip those off and apply a fresh set of pads. So be aware of what's in your AED. Some of them come with a face barrier, mouth mask barrier device, some don't. Some will come with razors, some will come with trauma shears, some will come with 2 sets of adult pads, some will come with a child set and an adult set. So just be aware of what's your what is packed with your AED. More and more we're seeing now stop the bleed kits as well being packaged with your AEDs. We're going to dive in and talk about 2 rescuer BLS here.
For many healthcare professionals, a 2-person or team rescue is a more common occurrence.
I don't feel right.
Let me get your nurse. Josh, come here.
Sarah, what's going on?
I...
Hey, are you okay? Are you okay? Activate the rapid response team and get the code card.
She doesn't respond. She's not breathing normally, and she doesn't have a pulse. The first rescuer to arrive should begin CPR with chest compressions and ventilations.
1, 2,
Apply pads
3,
to
4,
patient's bare
5,
chest.
6, 7, 8, 9, 10, 11, 12.
Turning on the monitor defibrillator and attaching the pads should occur during compressions to limit pauses.
Plug in pads connector.
27, 28, 29.
Do not touch the patient. Analyzing heart rhythm.
Clear.
The monitor defibrillator is analyzing the person's heart rhythm and will advise if a shock is needed.
Shock advised. Charging. Stay clear of patient.
Clear.
Make sure that no one is touching the patient before the shock button is pressed.
Deliver shock now. Press the shock button now. Shock delivered. Start CPR.
1, 2, 3, 4, 5, 6, 7.
It's important to count out loud while delivering chest compressions so the second rescuer knows where you are in the CPR sequence. The airway person should position themselves at the head of the patient. Remember to watch for chest rise with each breath and avoid excessive ventilation. The airway person should also provide feedback to the compressor to ensure that chest compressions are provided at the correct rate and depth, and there is complete chest recoil between compressions.
Good compression rate and depth.
19, 20, 21, 22, 23, 24, 25, 26, 27, 28.
The compressor should pause compressions while ventilations are being administered until an advanced airway is inserted and secured. We'll talk about advanced airways in more detail later.
8, 9.
Next time the monitor defibrillator analyzes, let's switch.
Okay, 15, 16, 17, 18, 19, 20, 21, 22, 23.
Plan to switch roles as the compressor every 2 minutes, or sooner if the compressor is fatigued. That's about 5 cycles of 30 compressions and 2 ventilations. Switching roles should take no more than 5 seconds to minimize the interruptions in chest
12,
compressions.
13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
Do not touch the patient. Analyzing heart rhythm.
Clear.
No shock advised. Start CPR.
If you're performing CPR without a monitor defibrillator, you should switch roles when fatigued or after every 5 cycles of 30 compressions and 2 ventilations. That's about every 2 minutes. We'll learn more about how to effectively switch roles in the team dynamics section of the course.
So here we were able to see how that 2 rescuer team dynamic works, and we'll talk about more about that in the team dynamic. But just some key things to highlight is you're pushing at a rate of 100 to 100 compressions a minute. You're doing 30 cycles of 30 compressions to 2 breaths. Now, however you and your partner work on that, just make sure every 5 cycles you're switching, or sooner if you're becoming fatigued. And you're doing seamless transitions. You're taking 5 seconds to switch. The idea is to minimize those interruptions. In bigger teams that are practiced and experienced, they're going to start. They're waiting for you to get fatigued, and they're going to jump right on that chest. So just something to consider. Remember, maintain that ratio of 30 to 2 unless there's an advanced airway. 1 person is on the chest, 1 person is on the airway, and or the AED. Depends on when that AED comes in and comes into play. Something to consider is the individual that was compressing could potentially take over the AED as fatigue sets in. So 28, 29, 30, 2 breaths, then switch. So whoever was on the breaths can now continue compressions while the AED is being applied. So counting out loud helps. It helps for a couple of reasons. One reason is that when you're working with another person, they are anticipating that, okay, I have this airway open, I'm going to give a breath in, okay, 28, 29, 30, breath, breath. Also, it helps scene awareness. If there's other bystanders that can help, they can come and help with that. If you have another team responding, they can usually follow the subsequent counting of 30 to 2. Remember, at least 2 inches on the adults. apply those pads during compressions as best you can, and then deliver that shock as soon as possible. So just some considerations with that two-person dynamic. So we're going to dive into team dynamics here and kind of outline how that looks like.
You may be on a team with rescuers who are trained in advanced life support. However, no matter the skill, procedure, or equipment used in a resuscitation event, BLS is the foundation of all resuscitation attempts. Effective team dynamics increase the chances of a successful resuscitation. Everyone on the team must understand not just what to do in a resuscitation attempt, but how to communicate and perform effectively as part of a multi-rescuer team. Where people and resources are more readily accessible, the real challenge becomes the coordination of rescuers and resources when there are a lot of people involved. Successful teams not only have medical expertise and mastery of resuscitation skills, but they also practice good communication skills and adhere to the key elements of effective team dynamics. Let's watch the following example of good team dynamics so that you can see how an effective team works together during BLS. We understand that real-life scenarios may be more chaotic and don't always run as smoothly as demonstrated in this next video, but it's important to effectively communicate and work together for the best outcomes for your patients.
Okay, everyone, EMS just called in and said they have a 40-year-old male patient who is in cardiac arrest. Pamela is meeting them in the ambulance bay. She'll be in charge of the airway and ventilations when the patient arrives. James and Aaron, can you two alternate performing chest compressions and using the monitor defibrillator? James, you'll perform chest compressions first, and Aaron, I'll need you to manage the monitor defibrillator.
Yeah, I'll start in compressions.
I'll manage the monitor defibrillator and be the CPR coach.
Lawrence, can you take IV and meds?
Yes, I'll take IV and meds.
Kayla, can you record?
I'll record.
Great.
2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21,
Hi,
22,
we are a
23,
BLS crew
24,
here with a 40-year-old
26,
male
27,
who arrested at
28,
home.
29,
Return of
30.
spontaneous circulation was achieved. The patient arrested again while in transport to the hospital. We started CPR and gave one shock with no return of spontaneous circulation.
Okay, thank you. Let's move him over at 30.
15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
All right, let's move in 1, 2, 3. Okay, I'll take over compressions. 1, 2, 3, 4.
Good switch. James and Aaron, you can swap out compressions every 2 minutes or sooner if you get tired.
Okay, 16.
I'm
17,
recording.
18, 19, 20, 21.
Good
22,
compressions.
23, 24,
Plug in
25,
pads,
26,
connector.
27, 28, 29, 30.
Let's break down the example we just saw. Team dynamics is an element of high-performance teams and can be broken down into 3 categories: roles and responsibilities, communication, and debriefing. First, defining clear roles and responsibilities for the team is important. Every second matters during a resuscitation. Clear roles and responsibilities should be immediately established by the team leader or the first rescuer on the scene. Most often, the team leader will delegate tasks on the basis of each team member's skill level. A resuscitation attempt goes more smoothly when all team members know their roles and responsibilities. Often, the team leader will be at the patient's feet. However, the team leader may need to move around to observe and evaluate the skills of the team and provide feedback when needed. They may also assume responsibility for roles not defined. For the purposes of this video, we'll focus on the roles and responsibilities of BLS, which include the compressor, airway, monitor defibrillator, CPR coach, and the timer recorder. The compressor assesses the person and performs chest compressions. When giving compressions, rescuers should switch compressors after every 5 cycles of 30 compressions and 2 breaths, which is about every 2 minutes, or sooner if they become tired. The rescuer who maintains the airway should be positioned by the person's head. They are responsible for opening the airway and delivering breaths with a barrier device, pocket mask, or bag mask device. The airway person should watch for chest rise and avoid excessive ventilation. The rescuer assigned to the monitor defibrillator, or AED, is responsible for bringing and operating the device. They should be positioned next to the device, follow the prompts, and ensure that all team members are clear of the patient before delivering a shock if one is needed. When a monitor is present, its screen should be positioned so that other team members can see it. Be sure to establish a CPR coach early in the resuscitation attempt. Studies have shown that resuscitation teams with a CPR coach perform higher quality CPR with shorter pauses and compressions. The CPR coach's main responsibilities are to help team members provide high-quality CPR and minimize pauses and compressions. The CPR coach gives feedback about performance of compression depth, rate, and chest recoil. They should also give feedback on ventilation, including the rate and volume of the breaths given. The CPR coach can also adjust the environment to help ensure high-quality CPR. They can lower the side rails of the bed or stretcher, get a step stool, or roll the person to place a backboard and pads. The CPR coach needs a direct line of sight to the compressor, so they should stand next to the monitor defibrillator. The monitor defibrillator role could serve as the CPR coach. Finally, the timer recorder keeps a record of the events that occur, including frequency and duration of interruptions in chest compressions, time of shock delivery, and medications administered. Remember, medication administration is not a part of BLS, and it should be done by an advanced provider during a resuscitation attempt. The timer recorder also announces when interventions are due. When only 2 rescuers are present, they typically take on the roles of compressor and airway, with one of them also covering the monitor defibrillator and team leader. If 3 rescuers are present, they take positions around the patient in the 3 critical roles: compressor, airway, and monitor defibrillator. Every member of the team should know their limitations. Team members should ask for assistance and advice early, not when the situation deteriorates. Anyone on the team should speak up to stop someone else from making a mistake, regardless of role. The next part of team dynamics is communication. Knowledge sharing and summarizing information are critical components of effective team dynamics. It helps to ensure that everyone fully understands the situation. It can also help the team treat patients more efficiently and effectively. Team leaders should review what's happened and ask for ideas and observations from team members. Effective teams use closed-loop communication, the process of verifying that the message sent was received as intended. It's used to prevent misunderstandings and treatment errors. The sender gives the message, the receiver repeats it back, and the sender then confirms that the message was heard correctly. Closed-loop communication verifies that any assigned tasks have been completed. Teams should give clear messages to help prevent misunderstandings and keep everyone focused. All team members should use clear, concise language, speak loudly enough to be heard, and speak in a tone that is both calm and confident. Teams need to communicate with respect. Speak to each other in a professional manner, regardless of scope of practice or expertise. Resuscitation events are stressful, and emotions can run high. Understand that this is the nature of resuscitation, and remain focused on the life you're trying to save. The last part of team dynamics is debriefing. Debriefing allows the team to discuss how the resuscitation went, identify why the team took certain actions, and discuss whether anything can be improved in future events. Debriefing has been shown to help individual team members perform better and aid in identifying system strengths and deficiencies. Debriefing can occur immediately with the entire team, or be scheduled at a later time with the team and others. It's an opportunity for education, quality improvement, and processing of emotions after participation in a stressful event. Resuscitations can be traumatic for even the most experienced healthcare professionals. If you find yourself replaying the events, questioning your role in the resuscitation, feeling sad or angry, or not sleeping, these can be signs of post-traumatic stress reactions. Make sure you ask for help immediately so that a professional can help you process what you have experienced and what you are feeling.
So as far as that goes, team dynamics, BLS is the foundation. So in the beginning of the course, I talked about you can do all of the advanced care, push all the medications without that blood circulating, that those compressions pressing on the heart and the heart pumping the blood. Everything else is for naught. So think of it as a well-oiled machine. So communication is key. Make sure you're practicing closed-loop communication, especially when it is time to deliver shocks, secure an airway. Make sure you're calculating the medications and drawing up the right amount of medications and giving it at the right time during the resuscitative efforts. So be open to feedback. That's one of the identifying factors of being open to feedback, but also on giving feedback. So ideally, you're giving feedback in, I'm noticing decreased compression depth. Well, on the flip side, now I need you to increase your compression depth, push a little bit harder, push faster, push slower, little things like that. Know your limitations. So slip, trips, and falls a couple days ago, you're just not feeling up to it. Your shoulder hurts. Maybe compressions is not for you that day. Let your team leader know that, hey, I'm kind of out of commission. Can I be the recorder? So, and I think being open and transparent about that. Early feedback before the situation deteriorates. There's a lot of emotion that happens with cardiac arrest and the resuscitative efforts. So just be open to that discussion. Clear roles and responsibilities are important. Make sure. I like to practice when I enter a room. Hey, I'm Steven. I'm going to be compressor. Hi, I'm Steven. I'm going to be medications. Hi, I'm Steven. I'm on airway. So once your team knows their clear roles and responsibilities, then we can advance a little bit more streamlined. If you're on the chest, you're doing compressions, you're fatigued, let your team know, hey, I'm getting fatigued. Can somebody switch out with me? And then coordinate that switch. 1, 2, 3, switch, and you then switch. So we're talking about timer recorder as a role, team lead, compressor, somebody on the airway, medications, even though that's more of a advanced life support aspect of things, but something to consider. A CPR coach, making sure that they are there timing and minimizing those interruptions as well as monitoring those feedback devices, and then somebody on the monitor defibrillator. So, and a lot of those can be combined. The AHA also recognizes that these events are stressful. They also are they're bringing debriefing into these scenarios. So discuss how the resuscitation effort went with your team. It can happen right after or at a scheduled time soon thereafter, just to start making sure that we're breaking down those barriers and start debriefing about these. A lot of things also that we're noticing is these debriefing the scenarios, we're giving it an opportunity for quality improvement, right? So if we measure things, we start to then improve for future events. This also gives you time to do a little bit of education. So be tactful with that, because at the same time, we're trying to process emotions during the debrief aspect of it. Now, if you are experiencing PTSD or the post-traumatic stress symptoms, please, that's another thing that the AHA strongly recommends. Ask for help, ask for colleagues' help, ask for therapists, ask for whoever that can be there for you. So if you're replaying the event and kind of beating yourself up over it or whatever the case may be, talk to a professional about that. So that's a strong recommendation from the AHA. We're going to dive into high performance teams, and the big things about the high performance teams is that chest compression fraction. So the CPR coach's role is to measure that, and you're measuring compressions to interruptions. The goal is 80% or greater. For every 10%, there's an 11% chance of survival increase. So just something to consider. We're talking about feedback devices, metronome. If you get a chance and you don't have a metronome device, download a metronome application for your cell phone. I have links in the supplemental for those applications. Also, start measuring the cardiac arrest resuscitative efforts, quality improvement. Measure the codes, measure the procedures, the interruptions, and timing intervals. The other big thing is practice. Practice, practice, practice. When you have a team that is dedicated, either a code blue team or a rapid response team, practicing together is key. A lot of code teams, if you will, in some facilities have never really worked together when there's a resuscitative effort that comes into play. The individual skills are important, but also the team dynamic. So I'm going to let this load up here to talk about the high performance teams.
A high-performing team achieves specific performance metrics, including a high chest compression fraction, or CCF. CCF is the proportion of time during a resuscitation attempt when the person is receiving high-quality chest compressions. You can only achieve a high CCF by eliminating pauses during high-quality CPR. The higher the CCF, the more likely the chance of survival. Targeting a high CCF of at least 60% is recommended, and a goal of 80% is often achievable with good teamwork. Research shows that a 10% increase in CCF is roughly equal to an 11% increase in survival. Pauses typically occur during intubation, rhythm analysis, pulse checks, compressor switches, and defibrillation. We'll address some best practices for minimizing pauses in some of these areas. But you'll also need to measure metrics for high-quality CPR at your own place of practice to identify other areas where pauses exist. You cannot improve what you do not measure.
1, 2.
Whenever compressions are paused, be prepared to immediately resume compressions.
The next time the monitor defibrillator analyzes, I'd switch.
Okay, I'll take over compressions then.
If a compressor needs to switch because of fatigue, coordinate the switch to happen as fluidly as possible, such as while delivering ventilations or during a heart rhythm analysis. When switching compressors, the second compressor should take over on the same side as the initial compressor. For seamless transitions, switching between cycles every 2 minutes is best.
1, 2, 3.
It's best practice to use real-time feedback devices during CPR.
Good compressions. We can switch when you get tired.
However, if a feedback device isn't available, a metronome can help establish the proper rate. If your AED or defibrillator doesn't have a metronome, you can download a metronome app to your mobile device before the conclusion of this course. It's not enough to know what to do or even how to do it. To obtain the best results, your team must perform both the what and the how with high effectiveness. That requires practice, and effective practice requires measurement. But measurement is only effective if you debrief the team, set goals to improve, and practice more. Again, you cannot improve what you do not measure.
We're going to talk about some special considerations. While the AHA does want you to understand this material, some of these would be probably not done, but nonetheless, we're going to talk about it. We're going to talk about mouth-to-mouth. So if there is no mouth barrier device, mouth mask barrier device with a check valve or filter, you can do mouth-to-mouth breathing. Now, you're talking about potentially people you know. If you want to do that, if you're not comfortable, then just continue with hands-only CPR. But you're going to do the head tilt chin lift, you're going to pinch nose, and then you're going to go mouth to mouth. Give 1 breath over 1 second with adequate chest rise and fall, 2 breaths, and then you're going to get back on that chest. Now, if you're doing mouth to mouth or mouth to nose and mouth for children, you want to put your mouth over their mouth and nose while doing the breaths. Breaths and ventilation. Agonal breathing is and can be a sign of cardiac arrest. So we're talking about snorts, snorting. Sometimes it's forceful. Sometimes they are fighting to get that breath in. They're going to be using accessory muscles potentially, and that is kind of the last-ditch effort of the body trying to draw in air. So just keep that in mind. Rescue breathing. Rescue breathing is someone that is in respiratory distress, respiratory arrest, but still has a pulse. So the guidelines recommend that for the adults, it is 1 breath every 6 seconds. And for children and infants, it's 1 breath every 2 to 3 seconds. Once again, we just want to do that 1 breath over a second. Now, with the children, they need more respiratory support because cardiac arrest is usually respiratory in nature in etiology. So it could be a foreign body airway obstruction, could be a respiratory disease, bronchiolitis or croup or epiglottitis, whatever the case may be, versus the adults where it's just usually the heart itself. They're exhibiting the effects of a heart attack. So talking about advanced airways, not necessarily defined by the American Heart Association as just an endotracheal tube. They're putting endotracheal tubes, laryngeal mask airways, combi tubes, iGels, King airways, and even trachs into this category. And essentially it is any tube that is connected to their respiratory tract in some way, shape, or form that you can connect a bag valve mask to or a ventilator to and ventilate them. Now, just keep in mind that when somebody has a tube sticking out of their mouth, meaning they're intubated or they have some type of supraglottic airway, that it's 1 breath every 6 seconds. We're not pausing. We're not doing 30 to 2. We're doing continuous compressions, a rate of 100 to 120 beats per minute at a depth of at least 2 inches. And then we're breathing 1 breath every 6 seconds. So the consideration also, if it's a child, that it is 1 breath every 2 to 3 seconds. Talking about opiate associated emergencies. Now, one thing to keep in mind at the beginning of the course, safety is paramount. So keep your eyes open and situational awareness. We're talking about paraphernalia, powders, sharps, needles, residues. It's probably conducive to wear some gloves to give you some barrier there. We've seen some of these opiate overdoses now also spread to lay rescuer and then whoever is responding, first responder, doctor, nurses, law enforcement, EMT, fire scenes, you name it. So just be safe out there. Some opiate examples as far as what's out there. They can also be mixed with other drugs. So we're seeing opiates mixed with crack cocaine. We're seeing it mixed with Benadryl, with other types of medications, whether it be illicit or over the counter. And this doesn't have to be illicit opiates either, or recreational or prescription in nature. So just something to consider. Some examples are morphine, Dilaudid, fentanyl, heroin, carfentanil, methadone, tramadol, OxyContin, oxycodone. So it's not an all-inclusive example of opiates, but just something to consider. There's also modifications to the pediatric BLS algorithm where they're talking about opiate overdoses because they're getting into these medications. It doesn't have to be illicit drug use. It can be somebody is prescribed medications for pain, whatever the case may be, and the kids get into it. but also adults can forget that they took one, now they took another one. So forgetfulness can also lead to overdoses. So something to consider. Opiates work by depressing the neurorespiratory drive. They can still have a heartbeat. It could be weak and thready, but they might be not breathing or breathing slow, so 4 times a minute, sometimes gasping for air. In those individuals, this is where rescue breathing comes in. It becomes important. We want to make sure that we get naloxone on board as soon as possible. There's many ways of giving naloxone nowadays, IV, IM, as well as intranasally. There's no contraindications, and it can be given for pretty much any reason, especially if there's an unknown reason for this overdose. We're also seeing high incidence of opiate overdoses where you're going to need multiple doses of naloxone. So you can have 2 milligram doses multiple times, 4 milligram doses multiple times, just to get them to start breathing again. Now, at any given moment, they might arrest, so be prepared to start compressions. With the administration of naloxone, I do want to preface that these individuals, if they do regain consciousness, they might be confused, aggressive, they want to maybe fight, and it's really the fight or flight response with these individuals. They don't know where they were. Last they remember is what they remember. Now, all of a sudden, you have the response team coming to them, and it's not all about the high going away. It's the aspect of they just don't know where they are. And they might have been oxygen deprived for some time too. So you have that. So be ready for that. Be ready for some erratic behavior, maybe some vomiting. Narcan, naloxone does not last forever. So be prepared to give additional doses as they still have to work the opiate out of their system. So give rescue breaths if there's a pulse present. If not, start CPR. Apply the AED. Don't delay CPR for Narcan. So start CPR. Give that Narcan if it does not interfere with that. Also, if you need to leave for whatever reason, whether to go get the naloxone, to go get an AED, to call for help, whatever the case may be, the AHA recommends that you leave them in a recovery position, a left lateral recumbent, so laying on their left side with their knees kind of tucked in, and they also recommend to open their airway while you're doing that. And the idea is to help prevent aspiration. So there is a huge opiate epidemic happening. So that's one of the changes to the guidelines, that they're really bringing this to the forefront. I also want to talk about flumazenil versus naloxone. So some of these medications and opiates might be mixed with the opiates. So sometimes there's benzodiazepines that are mixed into it. The problem is flumazenil takes away the benzodiazepine effect, but at the same time, they might need that benzodiazepine for seizure activity. So it's kind of a hard aspect to balance. So a lot of times flumazenil is not really present around, and so Narcan will not reverse naloxone will not reverse the effects of a benzodiazepine. So just keep that in mind. If you need to administer flumazenil, administer it with caution. We're going to then talk about maternal cardiac arrest.
Treating cardiac arrest in someone who's pregnant can come with heightened anxiety because multiple lives are at stake. The best outcome for all depends on BLS rescuers summoning help providing high-quality CPR, and using an AED without delay. Compressions, ventilation, and AED use are mostly unchanged. If the person is clearly pregnant, indicated by a visibly rounded abdomen, and additional help is available, rescuers should perform manual lateral uterine displacement. To do this, use one or two hands to manually shift the abdomen to the left. This is known as left manual displacement. The uterus is no longer resting on the major arteries and veins that supply blood to the heart. This will allow for more blood to flow during CPR. More information about how to perform left manual displacement is available in your provider manual.
So the idea between the left lateral uterine displacement is that you are trying to release the pressure of the inferior vena cava. So as we're doing compressions, the blood can now return for the next subsequent compression. So increases blood return and flow. The next item we're going to talk about is drowning. It is something that is very important, and safety is key. Your safety is paramount. Make sure that these individuals are safe. I would rather that you call for help than you yourself becoming a victim. So just keep that in mind.
The World Health Organization estimates that there are about 236,000 deaths due to drowning worldwide each year. Significant efforts have focused on creating systems to prevent drowning, but an average of 4,000 fatal and 8,000 non-fatal drownings still occur annually in the United States, which is likely an underestimate. The drowning chain of survival can help you prevent drowning, respond quickly and effectively, and potentially save someone who is drowning. The first link in the chain is to prevent drowning. Preventing drowning starts with swim lessons, learning water skills like treading water, having pool fences, and wearing a U.S. Coast Guard approved life jacket, even if you are a strong swimmer. The next link involves recognizing a swimmer in distress so you can help. To help a struggling swimmer, first, make sure the scene is safe and shout for help.
Hey, are you okay?
Tell someone to call 911 and get the AED.
You, call 911 and get an AED.
Provide the struggling swimmer with a rope, pole, or flotation device to grab onto. The safest way to help a struggling swimmer is to remain out of the water yourself so that you don't become another person who will need help. Next, if you're able to do so without putting yourself in danger, move the person to shallow water, ideally in a flat position with their head above water or out of the water completely. Don't worry about clearing any water that the person may have in. It's not necessary.
Are you okay?
If the person is not responding and not breathing, you'll need to open their airway by using the head tilt chin lift maneuver and then give 2 breaths. Keep in mind that someone who dove into a pool or water with hazards could have a head or spinal injury. If you are concerned about a possible injury, use the jaw thrust maneuver instead of the head tilt chin lift maneuver. If for any reason you can't give mouth-to-mouth breaths, give mouth-to-nose breaths instead. If the person has a pulse, continue providing breaths. Check the person's pulse about every 2 minutes. If the person is still not breathing and not responding, they may be in cardiac arrest. If no pulse, start CPR immediately and use an AED as soon as one is available.
We're going to work on learning about child BLS. So child BLS essentially is very similar to the adult BLS algorithm. So I'm going to bring up the screen here. So here in this pediatric basic life support algorithm, right off the bat, you're seeing that it is infant to puberty. So make sure check the scene is safe. Check that the scene is safe. Tap and shout. Check for responsiveness. Activate that emergency alert system. Check for pulse. Check for breathing. With the children, checking either the brachial or the femoral pulse is recommended. The change between the adult and the child is that we're talking about one breath every 2 to 3 seconds if they have a pulse but are not breathing. Also, if their heart rate is less than 60 per minute, despite poor perfusion, despite oxygenation and ventilation, start CPR. The aspect of it is that they have a low oxygen reserve. We want to make sure that we're helping them with that. Was this sudden cardiac arrest witnessed? If it was witnessed, activate the emergency alert system. If it was not witnessed, we want to do 5 cycles of CPR, 30 to 2 if you're by yourself. So we want to make sure that we are compressing at 100 to 120 compressions per minute with a depth of 1/3 of the AP diameter, approximately 2 inches. A child is defined as 1 year old to signs of puberty. So we're talking about facial and chest, pubic, armpit hair for the boys, as well as breast development for the girls. Another change that's happening in 2025 is we are looking at one-handed or two-handed compressions. We're noticing as well as decreased compression depth. So the AHA recommends one-handed, and if you can't get that approximately 2 inches, then switch over to two-handed compression depths. The compression and ventilation rate is 30 to 2 if you're single rescuer. If there's 2 rescuers, it's 15 to 2. Once again, they have a low oxygen reserve. Most of the cardiac arrest happens because it's a respiratory in origin, so we're breathing more often. Something to keep in mind, I like to rhyme a little bit, but I cannot take credit for this. A fellow instructor kind of uses it, so I'm borrowing it. It's 30 to 2 no matter who, if it's just you, right? So no matter the age, if it's just you, it's 30 to 2. If you have a friend, it's 15 to 2 for children as well as infants. Please be mindful, don't overextend their head and neck during ventilations. Their trachea is still developing, so hyperextending their airway can occlude it, so you don't want to overextend their head and neck. AED use. With children, follow what the AED recommends, but most of the time it'll probably be anterior-posterior placement of those pads. You can put them anterior-lateral as long as the pads don't touch and overlap. Also, if you have pads with an attenuator, use those. Don't cut the adult pads. If you don't have an attenuator with pediatric pads, then use just the adult pads. So we want to do 2 minutes of CPR, check for rhythm, check for shock. If no shock advised, continue CPR. If there is a shock, deliver the shock, making sure you're clear, I'm clear, you're clear, we're all clear. Deliver the shock, and then continue CPR. Going over infant BLS, the steps are very similar. One key change is now we are not doing the 2 fingers on the chest. We are doing either the one heel of the palm or thumbs encircling. So the thumbs encircling is the preferred method for 2 rescuers, but you can also do the single palm method. we're just seeing a lot of the compression depth is not being achieved. For the infants, it is also 1/3 the AP diameter. It is approximately 1.5 inches. So just keep that in mind. Minimize interruptions to less than 10 seconds, 100 to 120 compressions per minute, one breath over 1 second, 30 to 2, no matter who, if it's just you. And then if it is a team member is with you and you have a second responder or rescuer, it's 15 to 2. Infants are defined as 1 month of age to 1 year of age. So, and also, just as I said before, if you have naloxone available and you suspect an overdose, administer the opiate antagonist. So, the algorithm is still the same. If you found them unresponsive, then you want to make sure that you're going to give them 2 minutes of CPR before you leave and activate the emergency system. One also key takeaway is babies are kind of portable, so maybe bringing them with you if you're going to activate emergency system. If it's a witnessed arrest, you can just you can leave and get that emergency system activated, or get the AED or whatever the case may be. So just keep that in mind. We're going to talk about foreign body airway obstruction. There was a change in 2025 where we're not doing only abdominal thrusts for the adults and children. We're doing abdominal thrusts and we're doing 5 back blows or slaps. So in the algorithm, we want to start with 5 back slaps or back blows. Then we're going to do abdominal thrusts. So that's a key. We want to start with the back blows, then abdominal thrusts. It's 5 of each. So 5 back blows, 5 abdominal thrusts. And you're going to repeat that until the object is expelled, pop the cork, or they become unresponsive. If they become unresponsive, start CPR. The modification to CPR is that when you go and open their airway and give breaths, you want to look in their airway and pull the obstruction out if it is easily viewable, so if you can see it, and then easily reachable. If you can reach it and pull it out, pull it out. Please do not do a blind finger sweep, and if you cannot reach it, please don't go reaching for it. More often than not, these airway obstructions become more severe if you start poking around and you can't reach it. If you need to deliver breaths, go ahead, do so. Nice, easy breaths with either bag valve mask or mouth to mask, in hopes that the obstruction will loosen up and you can either blow past it or it can be blown into their right lung, right main stem, and then you can ventilate and oxygenate that left lung. So, the signs of foreign body airway obstruction, right? You have the universal grasping at the neck, poor air exchange, a silent cough. They can be changing colors, right? So gray, you're talking about bluish cyanosis around the mouth. They might be drooling. They're not able to talk. You want to ask them 2 questions. Are you choking? And do you need my help? Right? They're still awake. They're still alert. Ask for nice and easy consent. If they don't need your help, don't leave them. You know, hey, I'm here for you. Just let me know if you need help. But they sign, nod, or mouth yes, then go ahead and help them. Early activation of the emergency response system is key here. Even if it's fairly severe and it's maybe not a complete airway obstruction, I think it would be prudent to call 911 and get a emergency response team activated. Starting with the 5 forceful back blows, 5 back slaps. If that doesn't work, give them 5 abdominal thrusts. Special considerations. for the children, right? Get down to their level. You don't have to pick them up to do that. You get down to their level. Large individuals, large persons, you want to go reach under their armpits, go to the middle of their chest, and then just squeeze and pull back. So large persons, pregnant, and anybody in a wheelchair. Be aware with the wheelchair, especially the electronic or electric wheelchairs, that they might have features where they lean back and forward, so on and so forth. Just be aware of features that might pin you in or pin you down or injure them as well. So we've seen that happen. You're going to continue that until the cork pops or they become unresponsive. If they become unresponsive, lower them to the ground, start CPR with compressions, open that airway, look for that obstruction, remove that obstruction if possible, and then continue CPR. For the infant, it is slightly different. Please do not do abdominal thrusts on your infants. It's soft, it's squishy, they're still growing. You can cause a lot more injury if you do that. So please refrain from doing that. It's very similar as far as the adult and child. You want to support their head and neck. You want to take them on your forearm, and you want to make sure that their hips are over their head. So you're essentially kind of holding them at a 45-degree angle down. You're going to give them 5 back slaps and then 5 chest thrusts. Now, when you're doing the chest thrust, you are not doing this. You are doing the one-handed palm, okay? And you want to be fairly firm and aggressive with these. So 5 back slaps between the shoulder blades and then 5 chest thrusts with 1 palm. If need be, mouth to mouth and nose is preferred for breaths for that. Here we can show you the child foreign body airway obstruction algorithm and then that infant obstruction algorithm. They're very similar. As we are concluding here, I want to talk about here's the algorithm for pregnancy. Okay. So something to consider. This is not part of the BLS aspect of it, but cardiac arrest and pregnancy algorithm also talks about prepare for resuscitative delivery. So make sure you call the appropriate individuals to handle that. But we want to make sure that we're pushing hard, pushing fast on that chest, manual uterine displacement to the left to decrease that pressure on that inferior vena cava. LVADs. LVADs are very common in the Chicagoland area as well as other metropolitan areas. The recommendation is that if you have an unresponsive adult and child that have LVADs, assist with ventilations if necessary and assess perfusion. So perfusion, you're talking about the color of their skin, cap refill, are they cool, clammy, diaphoretic? Do they have peripheral coolness but central warmth? And the aspect is LVADs are there, they're fluid dependent pumps, and they might not have a pulse. So now we're talking about getting a Doppler to try to see if I can hear their blood pressure, if you will, or hear a pulse, and the whirring of their machine and their pump in their abdomen. So things to consider. They're a lot more advanced aspect. Their family, friends, and other caregivers might be trained to deal with those. But the big thing is the perfusion adequate? If it is adequate, do not perform external chest compressions. We want to assess and treat non-LVAD causes of unresponsiveness, right? These individuals could still have traditional reasons why they are unresponsive, simple as a low blood sugar. So now, if they do not have adequate perfusion, you can perform external compressions. assess the LVAD function, right? See if there's any alarms, see if the batteries are charged, put them and plug them in if need be. Assess and treat non-LVAD causes for unresponsiveness as well. But the key thing is start CPR. So that's kind of the one thing that I wanted to talk about. Talking about the chain of survival again, I'm going to kind of repeat these. The chain of survival, now that there's a single chain of survival, it's intended to be applied on the adult and pediatric in-hospital cardiac arrest and out-of-hospital cardiac arrest. So it's just that single chain now. We don't have to memorize different chains for different things. Chest compressions for infants. The change is now one-handed heel compressions as well as two thumbs encircling. The two thumbs encircling is recommended for two rescuer CPR, but you have a choice to do either or. Opiate emergencies, opiate-associated emergencies now is part of the adult and pediatric algorithm, so it doesn't have its own separate algorithm. Severe foreign body airway obstructions in the infants. Now we're doing 5 back slaps or 5 back blows, and then 5 chest compressions or chest thrusts with 1 palm instead of the 2-finger method. We're bringing back 5 back blows, 5 back slaps, and 5 abdominal thrusts for severe body airway obstruction for children as well as adults. So that's just something to consider. And more opiate agonists in the algorithms. So this concludes the course. Here's some helpful links. elearning.heart.org. You can get more information there from the American Heart Association. Accessing your e-cards once issued is ecards.heart.org. You can get ebooks. I can issue ebooks, or you can purchase other ebooks for Heart Savers, ACLS PALS, and the like, and other materials from the AHA at ebooks.heart.org. If you're interested in other training offerings, I do all of the AHA Heart Saver, BLS, ACLS PALS, as well as the American College of Surgeons Stop the Bleed training at amerirescue.com. I recommend one of these 2 metronome apps on your phone. I have an iPhone, so I downloaded the app for iOS, but then it's also available for Android. Remember, it's 100 to 120 beats per minute. My recommendation is setting that metronome to 110. It's right there in the middle. If you go a little bit north of that or a little bit south of that, you're still within the 100 to 120. Here's the chain of survival. Early recognition and emergency activation is key. If you can call the cavalry, the sooner the better. High quality compressions is key. BLS is the foundation of all of the care algorithms that AHA has to offer. Early defibrillation, right? If your heart's quivering, the only way to fix that is to stop. And then in hopes, right? It removes the bad rhythm in hopes that a good rhythm takes over, right? Advanced resuscitation, that's your ACLS and PALS for your pediatrics. And then as well as post-cardiac arrest care. So that's all your return of spontaneous care, and then if they need further treatment for whatever was the cause of that cardiac arrest. Recovery and survivorship. So a lot of that is not only that the cardiac arrest is over and now there's a return of spontaneous circulation, it is now the care that takes over afterwards and the care that happens after they leave the hospital. So we're looking at 15 days post-event, 30 days post-event, 6 months post-event, 1 year post-event. So and making sure that they have treatments lined up if need be after their event. Remember, call 911 or your other emergency response numbers, especially in facility. Push hard, push fast. And also here, kind of the steps I outlined as this doing the CPR. Check for scene safety, assess the patient, Check for responsiveness, tap and shout at the same time. Activate the emergency response system. Please remember to delegate somebody, if you can, to get an AED and activate emergency response system. Check for pulse and breathing at the same time. And then right in the middle of the chest, push hard, push fast, 5 sets of 30 compressions to 2 breaths with a pocket mask, or if you have a bag valve mask and you have a second rescuer. 120 or 100 to 120 compressions per minute, at least 2 inches for the adults, approximately 2 inches for the children, and approximately 1.5 inches for the infants. Provide breaths with enough force to produce chest rise. 1 breath over 1 second each. Remember, minimize interruptions to less than 10 seconds. And then when an AED arrives and becomes available, turn it on, follow the prompts. Well, thank you for your time. If you have any questions and concerns, please don't hesitate. Send me a message. Website is amerirescue.com. You can always fill out the contact form there and ask the questions. If I can't get you an answer, I will find somebody that will. Thank you very much.